Today I'm so pleased to speak about one of the important topics in nephrology, which is contrast-induced acute kidney injury. Why it is very important? Because it hits one of the important targets, which is prevention of acute kidney injury. The strength of any community is measured by the contribution of preventive medicine to curative treatment. So as known to all the people, prevention is better than cure. This session is delighted and sponsored by the Egyptian Society of Nephrology and Transplantation as continuous nephrology education. So before I'm going to speak about the definition and classification, I'd like to thank Professor Tariq El-Baz, the President of Egyptian Society of Nephrology, for supporting these scientific activities, and Professor Khaled Aouda, the General Secretary of Egyptian Society of Nephrology, for his contribution and kind care. This is our mission and vision in continuous medical education in general and in nephrology in specific. Live as if you were to die tomorrow, and learn as if you were to live forever. The other statement by Albert Einstein, the only thing that interferes with my learning is my education, Albert Einstein said. But I want to modify these statements. There is nothing to interfere with learning, because even when the person is educating or teaching other people, he is learned by this, so learning forever and all the time. The outline for definitions, classification, and clinical presentation will be discussed under these sectors: introduction, slides, and classifications, definitions, incidence, pathophysiology, and I'll end by the clinical presentation of contrast-induced acute kidney injury. To start with, contrast is everywhere in all specialties. So all specialties depend on the contrast for diagnosis and the management. As you see here, this is the cardiac catheter, depending on the contrast, cerebral strokes to diagnose cerebral strokes and hemorrhage, cerebral angiography by contrast. Here, CT angiography to diagnose pulmonary embolism, and the hepatoma, CT with contrast to define hepatoma. Peripheral vascular disease depends on in its diagnosis on the contrast use, even to know the morphology of urinary system, kidney, ureter, bladder. This is intravenous sonography. The old name is intravenous biolography, but it's changed because we can know everything about the kidney, ureter, and bladder. This is one of the cases of renal transplantation. As you see here, there is artery stenosis, and after diagnosis of graft artery stenosis, MRA, invasive angiography was carried out, and the balloon is inflated, and then the lumen is resumed, as you see here. So by these two slides, contrast is used for diagnosis and intervention to treat many diseases. So it is very essential and present in all specialties. There are principally two classifications or two types of contrast: iodinated contrast materials and gadolinium-based contrast material for magnetic resonance angiography. Before I'm going to discuss these types of contrast, I have a question. Regarding retinal fluorescein angiography, is it associated with contrast nephropathy? I imagine that retinal fluorescein angiography, which depends upon sodium fluorescein, is not nephrotoxic. And whenever I received a call from my colleague from the ophthalmology, I said to him, go ahead, no problem with the contrast, because this is not iodinated contrast and no hazards. Until I read this article about the effect of fluorescein on renal function among diabetic patients. And this study, although it included few number of patients, approximately 40 patients, but creating increase in 8 or 9 of them. So I cannot say absolutely that fluorescein angiography is absolutely safe, but it is still I consider it safe in comparison to iodinated contrast or gadolinium contrast materials. The classification of iodinated contrast material depends on osmolarity of the contrast and ionicity. By osmolarity, we compare the osmolarity of the contrast to the plasma or the blood. So we have principally 3 classes according to osmolarity: high osmolar iodinated contrast material, low osmolar, or isoosmolar. The high osmolar is more than 5 times the osmolarity of the blood. Low osmolar is 2 to 3 times greater than blood, and isoosmolar has the same osmolarity as the blood. And the contrast then classified to ionic or non-ionic, monomers or dimers. And these tables show the different types and the generic names of different contrasts. As you see here, the high osmolar has osmolarity 1500, more than 5 times the plasma. And this is the non-ionic. Generally, non-ionic is less toxic than ionic. And the low osmolar or iso-osmolar are less toxic than high osmolar. And these are the examples of low osmolar, and these are examples of iso-osmolar. As you see here, the low osmolar between 500 and 600, 2-3 times the blood, and here like the blood in the iso-osmolar. So the lower the osmolarity and the more the non-ionic of the contrast, the less is the toxicity of this contrast. These are the basic structure of different iodinated contrast. This is the ionic monomer. This non-ionic monomer, low osmolar, iohexol, and this is iso-osmolar iodexanol type of the iodinated contrast material. The gadolinium used in MRA is the name came from the Sir Johann Gadolin. He was the grandfather of gadolinium. He discovered this material, and the first name of gadolinium was Ytterbium, and this according to the place discovered where the gadolinium was discovered. By the way, gadolinium is not so rare. It is tenfold than the concentration of iodine in the nature. There are many types, 9 types of gadolinium, as you see here, and the classification is linear, cyclic, non-ionic, or ionic, and I'll discuss this later. So let us concentrate on the iodinated contrast material, because in the publications all data are concerned with iodinated contrast material. So what is the definition of contrast-induced acute kidney injury? This is the basic definition. 3 criteria should be fulfilled to define contrast-induced acute kidney injury. Number 1, or the first component of the definition, this is an iatrogenic disorder. Iatrogenic because it occurs after injection of the contrast, which is characterized by absolute rise of creatinine by 0.5 milligram per deciliter, or increasing creatinine by 25% of the baseline creatinine after exposure to the contrast. So this is the first component of definition, increasing creatinine. So if I have a basal creatinine, suppose it is 1 milligram per deciliter, and after the contrast becomes 1.5, this is within the definition. And the second component, this rise of creatinine should occur with this time frame. So it occurs principally after 1 day to 2 days of the contrast, and reaching the peak within 3 to 5 days. So if you have a patient who received the contrast and you have a baseline creatinine, and there is no rise of creatinine after 5 days of the contrast, and later the patient has rising serum creatinine, this is not contrast-induced acute kidney injury. So we should respect the time frame. The third component to diagnose or define contrast-induced acute kidney injury is that there should be no alternative explanation for the rise of creatinine. Suppose that you have a patient who received the contrast, but after receiving the contrast, he received another nephrotoxic drug or suffered from dehydration. So dehydration or the use of other nephrotoxic drug can explain the rise of creatinine. At that time, you cannot say this is a contrast-induced acute kidney injury. Again, to define contrast-induced acute kidney injury, 3 criteria should be fulfilled. Rise of creatinine by 0.5 milligram per deciliter, or 25% from the baseline creatinine, occurring with the time frame from 1 day to 2 days, reaching the maximum peak within 5 days, and there is no other alternative explanation for the rise of creatinine. By all 3 criteria together, you can define the contrast-induced acute kidney injury. So, and regarding the guideline stated that was recently published, that we can use the classic definition of acute kidney injury that is based on RIFLE, Rifle Classification Scheme, or AKIN, Acute Kidney Injury Network Scheme. So an individual who developed changes in kidney function after administration of intravascular contrast media evaluate for contrast-induced acute kidney injury, as well as for other possible causes of acute kidney injury This is very nice because, as I mentioned before, you should exclude other alternative diagnoses that explain the rise of creatinine. This is the classic and basic rifle criteria that depends on urine output, creatinine, and estimated GFR. And this is the acute kidney injury network classification that is classified into 3 stages, stage 1, 2, and 3. So stage 1, just rise of creatinine by 0.3 milligram per deciliter, put the patient in the stage 1 of acute kidney injury. So this is a very nice paper because it discusses early creatinine shift. So if you have a patient with basal creatinine, for example, 1 milligram per deciliter, and after 12 hours there is a rise by 0.5 or 10%, 5% or 10% from baseline. So from 1 to 1.1 after 12 hours, you should put your eye on this patient by repeating creatinine, because this patient may have the well-established definition of contrast acute kidney injury. And this is the slide, increasing 5 to 10% increment of serum creatinine compared with baseline after 12 hours. And this is the sensitivity and specificity of this change, this minor change with the establishment of the diagnosis of contrast-induced acute kidney injury, and even the persistence of this injury with satisfactory sensitivity and specificity. Another definition extrapolated from this study that included 58,000 patients undergoing percutaneous coronary intervention, and the definitions including 3 definitions. The classic and traditional definition, which is based on rising of creatinine by 0.5 milligram per deciliter, and the new definition that include either 0.5 milligram per deciliter rise of creatinine or a rise by 25% from baseline creatinine. And the third one, which is known as CIN incremental. What's meant by CIN incremental? If you have a patient, his basal creatinine is 1 milligram per deciliter, and then creatinine after the contrast became 1.25. This means that there is rise of creatinine by 25% from the baseline. But this is not achieving the absolute 0.5 milligram per deciliter. So the incremental is those patients who have rising by 25%, but there is no, they didn't reach the absolute 0.5. Another example, if you have a patient with basal creatinine 4 milligram per deciliter, and after the contrast became 5, this is a rise by 25%. This new definition extrapolated from the Michigan Cardiovascular Consortium depends upon the absolute rise of creatinine by 0.5. This is the traditional. The new classification, the patient has rising creatinine either 0.5 or 25% from the baseline creatinine. And the third one is the incremental. What is the definition of incremental? This is a patient who has rise of creatinine by 25%, but this didn't reach the 0.5. For example, if we have a patient with basal creatinine 4 milligram per deciliter, and then creatinine after the contrast became 5, this is 1 milligram per deciliter rise, but in the same moment it is 25%. So it is 25%, but exceeding 0.5. So it achieved the basic definition and 25% definition. On the other hand, if you have a patient with serum creatinine 1 milligram per deciliter, and after the contrast became 1.25, this is 25% rise, but didn't achieve the basal 0.5 milligram rise of creatinine. This is an important definition. Yes, it's important because it is correlated with the outcome. Look here, if you look at the deaths, if the creatinine increases by 0.5 milligram per deciliter, this is very important because significantly associated with increasing deaths in comparison to the other types. And the list is the incremental. And the other point, the patients who will suffer from nephropathies that necessitate dialysis, also the patients who achieved absolute figure 0.5 or more, this is the more risky. So from this definition, the most respected definition that's associated with hard outcome, either patient survival or kidney survival, is the rise of creatinine by 0.5 milligram per deciliter or exceeding 0.5 milligram per deciliter. If we use cystatin C for the definition, from the publication they found that if serum cystatin increasing by 10% from the baseline, suppose that you have patients with baseline serum cystatin C, and cystatin C was repeated after the contrast, and you find the rise is exceeding 10% cutoff point, this is associated with 21% of the patients, and the negative predictive value for that, for the contrast nephropathy, is 100%, and the positive predictive value is 39%. What does it mean, negative predictive value and the positive predictive value? This means that if you have a patient with baseline cystatin C, and you have this patient with another value of cystatin C after the contrast, and you find that there is no rise of cystatin C by 10%, we'll be sure that the patient will not have rise of creatinine and no contrast-induced nephropathy. This means that cystatin C is a good negative if you have follow-up serial of cystatin C. But if you have cystatin C follow-up and you find it exceeding 10% of baseline, this may denote the development of contrast nephropathy or not, because the positive predictive value is low, 39. So cystatin C is a good negative and not good positive. Good negative to exclude the diagnosis. Just to show the importance of contrast-induced acute kidney injury, acute kidney is considered the third most common cause of acute kidney injury in hospital, following hyperfusion and use of nephrotoxic drugs. And the epidemiology of de novo acute kidney injury related to the contrast in critically ill patients is not well known. The incidence of contrast-induced acute kidney injury ranges from 1.3% to 70%. Why this very broad range? Because the difference in definitions, difference of the contrast used, and the absence. So the majority of patients have the baseline creatinine, but the majority didn't. They don't have the creatinine followed up serially. And the contrast-induced acute kidney injury required dialysis range from 0 to 7%. In a prospective study evaluating 600 patients for whom they were exposed to contrast-enhanced CT of the abdomen, contrast-induced nephropathy occurred in 11% of the patients. Another study showing, depending on acute kidney injury network, if you look here, if you use the cutoff point to 0.5 milligram per deciliter or 44 micromole per liter, and you follow up the creatinine either after 2 days, 3 days, or 4 days, you'll find that the incidence is different. So incidence differs according to the definition you use and the follow-up of creatinine you follow. Another factor that interrupt the or interfere with the prevalence or epidemiology is the use of different contrast. Here, iopimidol is low osmolar, and this iodexanol, which is isoosmolar, you will find different incidence. If there is more comorbidities, the more the comorbidity the patient has, the more the incidence of the contrast-induced acute kidney injury. The pathogenesis of contrast acute kidney injury depends on several factor effects, obstruction and hemodynamic effects. So several effects including vacuolization, necrosis, apoptosis, all these lead to contrast-induced acute kidney injury directly, or the obstruction of the renal tubules, or the either osmolar dependent or independent pathways. Here the osmolar independent pathway depends on endothelin A stimulation, or osmolarity dependent pathway dependent on adenosine 1 stimulation, ending with vasoconstriction, medullary hypoxia, and free radicals. All of these factors lead at the end to a contrast-induced acute kidney injury. The pathogenesis is important, but when you follow the treatment and the prevention of contrast-induced acute kidney injury, you'll find that it is very important from the theoretical point of view, but there is, when you apply the treatment that tackle or hit the pathogenesis, you'll find different in the outcome in studies. Again, this is a more recent paper that discusses that the pathogenesis for contrast-induced acute kidney injury is intricate, including affection of many cells, endothelial cell, vasoconstriction in the medulla, and hypoxia, free oxygen radicals. And the conclusion of this study is that if we want to decrease contrast-induced acute kidney injury, we should have a drug that attack all the pathways. Regarding the clinical presentation, there are some tricks in the presentation. Contrast-induced acute contrast material can interfere with the utility of urine analysis. So we recommend not to do debit stick or estimate proteinuria 1 day or 2 days after the contrast use, because it will give you false positive proteinuria. Again, the presentation is rise of creatinine, so generally non-oliguric acute kidney injury. Serum creatinine increases within the time frame, as I mentioned before, 1 to 2 days, reaching the peak within 3 to 5 days, and the rise is between half milligram per deciliter to 3 milligram per deciliter, and return to normal within 7 to 10 days. Another important point is to examine the urine, because as you know, urine examination is the liquid biopsy of the kidney. So examine the urine specimen with the low power to detect granular crust, because acute kidney injury related to contrast is basically acute tubular necrosis, and to examine the urine by high power to evaluate the renal tubular epithelial cells. And you give the score. If you have nothing, no granular crust, no epithelial cells, this is 0. If you find from 1 to 5, this is 1 point. Above 5, this is 2 points, and at the end you make the total score. If you reach 3 or more, this predicts the poor outcome. And this is just to show you, this is the epithelial cells, and this is the granular crust. So here you find the 2 epithelial cells, so you can give the patient a coronary epithelial cell 0.1, and here more than 5, so here 2. Total score for this patient is 3. Again, the biopsy, this is a normal kidney biopsy. You can find the tubules are back to back with delicate interstitium, but this is the slide from the up-to-date. You can find here the epithelial lining is damaged, and the cell debris everywhere in the lumen. So this is a well-established acute tubular necrosis. If you do biopsy, you can find these changes. Again, the majority of the patients recover completely. Some have residual renal dysfunction, about 30%. A very small percentage of contrast-induced acute kidney injury develop creatinine above 5, requiring dialysis either for short-term or long-term. And for the diagnostic issues, this is different biomarkers used to diagnose acute kidney injury in the cardiac bypass surgery. You can find here all the biomarker increases within a couple of hours from the event, especially this NGAL, which is neutrophil glutinase lipocalin. And this study showed that we can use lipocalin to predict the contrast-induced acute kidney injury with the area under curve is okay. Another point, from the radiology perspective, this is a study that was published 2 decades ago, and this study included 96 patients, who all of them were high risky for the contrast nephropathy, and they undergo aortography. And after 24-hour days, these patients were exposed to another non-enhancing CT scan to evaluate if there is persistent enhancement or not. So this study is a prospective study, putting in consideration to, after giving the contrast, they repeated CT but without contrast to examine the CT scan, to examine the kidney according to the persistence of the contrast by measuring the Howens field unit. So if there is persistence of the enhancement, this predicts contrast nephropathy. Another recent study, but here it is not prospective study. They don't put in their mind to do CT scan to diagnose enhancement. But if you have a patient and you give him contrast, and then the patient necessitates follow-up CT without contrast in the hospital, please put your eye on examination of persistent enhancement or not. So this was the aim of this study. So repeating the CT scan without a contrast within a week from the contrast to show the contrast. If you look here, all the kidney here, there's persistent enhancement in the cortex and the medulla. Here in the cortex only, here there's some streaks. So the higher the enhancement, the higher the risk of nephropathy, and as the more the enhancement, the more the nephropathy, and these are the different patterns of enhancement. Again, I will not recommend to do CT scan to diagnose contrast-induced acute kidney injury. But if you have a patient who received CT with contrast, and then you order for him for another indication, CT without contrast while he is in hospital, please look at this data because it may help. Again, the differential diagnosis, like any acute kidney injury, you should put in mind dehydration, nephrotoxic drug, nephritic, ischemic renal. If you look to this slide, the arrow refer to the artery which is occluded, and all these are ischemic infarcts. And here the arrow refer to white here. Why this white color? Because the total thrombus in the vessel, and there is some clearing of the cholesterol by preservation. So this is atherosclerotic renal disease or cholesterol impulse syndrome. The most important phenomena here is that we should look at the time frame. If you have creatinine, basal creatinine, after 1 week no rise of creatinine, you cannot say contrast-induced nephropathy, but it is atherosclerotic renal disease. This is the appearance of the cholesterol emboli leaving empty space known as cleft. So although the slide is very beautiful, but carry a bad prognosis, there is no treatment for that. And I will end this sector of the presentation by the work group recommend that when a recent creatinine is not available, look at urine analysis. If urine analysis is perfect, you can go for CT scan. But again, I recommend not to do any radiological investigation with contrast except after you have creatinine.